Yes, I must admit I was a bit, thank you first of all for inviting me here. I was a bit worried that my presentation was a bit odd compared to the other overviews of the Nordic countries here, because this is not specifically Nordic. But having listened to the previous presentations, I think that it could fit quite well in. So it's not the organizer's fault. If it doesn't, then it's my fault. The title of my presentation is Inequality and Interventions. How could inequality be reduced? And that's, of course, a very important question. Yes. So even though it has been said quite a lot about potential explanations for health inequalities, I would try to summarize some of it and present two types of explanations for health inequalities as I see them. They are not mutually exclusive, of course, but usually they are two sides of a debate how to address inequalities in health. And the first one have been mentioned here. It's the hypothesis of social determinants of health. And it says basically that it's the social distribution of the determinants of health as they were defined by Marmot and his co-authors of the final report of the Commission on Social Determinants of Health. It was defined as the social distribution of money, power, and other resources. And it's very clear that it's the focus on social structures, the structures that are responsible for this distribution. We've been talking about the welfare state here, and of course the welfare state, it's basically a mechanism to assure a fair and effective distribution of this type of resources, money, power, and other resources. We talked about democracy, about transfer, money transfer, etc. So what is the other one then? I have to find the right. So the other one would be, I've called it here the capability approach, limitations of agency. It focuses on the individual. So the emphasis is on human agency and its limiting factors. So it's basically a focus on individual behaviors. Here I think that this has been expanded in a very interesting way by Amartya Sen, who was mentioned here already in the beginning. That was good. I don't need to introduce him. He was a member of the Commission of Social Determinants of Health, but I think he provided this this picture, and I know that he's influenced Michael Marmot quite heavily in his thinking about health inequalities. He presented this basically most of this theory in his book Freedom as Development, which came out in 1999. So basically there are two hypotheses behind increasing health inequalities: the social structure hypothesis and the individual behavior hypothesis. Now I'm making it more simple in a way. So the social structure hypothesis, it explains the increasing inequalities in health because there is a change of social structures. The social determinants of health have become even more inequitably distributed. And what is responsible for that? Well, for example, widened income and wealth distributions, which we've heard of, stigmatization or discrimination of low-income groups or ethnic groups, growth of precarious labor market relations, growing inequalities regarding access to information, etc. All this has been mentioned. I was very happy. Then I understand maybe this could fit into the theme of today. The other hypothesis, individual behavior hypothesis. Well, it says basically that there's a backlash in health inequalities, which is paradoxically maybe partly made, or maybe even to a great extent made, by our own efforts to improve population health because of the predominant focus on changing individuals' behavior in health promotion policies. That means that the people with a good education, good income, and good resources have been able to adjust their behaviors, while people with lower resources have not been so successful. And that has increased the inequalities. So when we talk about behavior, quite common, we mentioned two determinants of behavior, namely knowledge and attitudes. And we know that knowledge transfer favors the well-educated. For instance, it's important to identify with the language of the sender, and if it's a well-educated community that sends the messages, then maybe it's not accepted the same way. It's accepted more by people with a similar educational level and a similar way of expressing themselves. So this is important for trust and the uptake. So a vertical approach is not beneficial for the perceived trust of a message. We also discussed trust here. Attitudes are linked to everyday culture and of social classes, gender, and ethnic belonging. For instance, prevailing constructions of low social class or masculinity are linked. I was hesitating, might be linked, but I think we can say they are linked to a concept of non-vulnerability and fatalism regarding health risks. For instance, concerning smoking, attitude to smoking, alcohol consumption, dietary habits, using bicycle helmets, etc. So this might be some things that operate. So this is important. If we want to intervene, we should have some ideas how these things operate and how we should intervene in these chains. So combining the hypotheses, I said they were not mutually exclusive, is a good rationale for launching community-based interventions for changing individual behaviors. In theory, this would have the potential to address both the mentioned mechanisms. We learned here that quite a lot of the differences in health inequalities was depending of some health behaviors like smoking and alcohol, etc. Yes, so we wanted to learn about the empirical evidence-based. It was said in the previous presentation in this room, in this parallel session, that the interventions that were made, they were not properly evidence-based and the dosage was too little. So what does really the empirical evidence base for community interventions targeting these health behaviors, what does it tell us about the potential to reduce health inequalities? So we made a search. I should also say that this project was initiated by the Public Health Agency in Sweden. So they are the sponsors of this, and then we decided to write an article about it. And I should also acknowledge my co-author. He will appear soon here, Andreas Wilhelmsson from my department. We made a search of the scientific literature and attempted an analysis of the findings. And this is the title of our publication, and it was published this year in Public Library of Science 1 in April. And the title is Reducing Health Inequalities with Interventions Targeting Behavioral Factors Among Individuals with Low Levels of Education, a Rapid Review. And I will explain why we named it a rapid review. We thought we would attempt a meta-analysis, but for reasons that I will mention, it did not come out that way. So important, of course, are the inclusion criteria. We wanted to look on interventions that were not based in the health sector, that address the general population or parts of the general population, and they should be targeting behavioral factors, and it should also include a different educational group, and they should be published in English in international peer-reviewed scientific journals, and the period was 1990 to 2015. And from countries with developed welfare systems that could be of interest for Sweden or for the Nordic countries. So they were from countries in Europe, North America, Australia, and New Zealand. So it should also be studies comparing those receiving the interventions with the control group and thereby applying one of the following study design. It could be randomized controlled trials or also experimental studies with a cohort design. So that meant if there was a community intervention, there should be a control area. And the studies should contain more than 100 individuals. So, I don't know if you can see this. This is sort of a main finding. So what happened to all... Could I make this bigger? I can't read it myself. But well, basically what it says was that we found, I think it was 1900 something. I can't read the figure now. the duplicates, and then it was something like 1,300, if I remember correctly. This is a memory test. And then we really scrutinized them. So we applied our inclusion criteria, and this number shrunk. So I think we read 130. Sorry. Yes, we screened 1,365, that is, for the inclusion criteria. And to our surprise, only 31 remained. So you can see the reasons why they fell out. They're listed there. I can't read those figures, but maybe it's too detailed. And then we applied some quality criteria, and there were actually only 9 left. And the quality criteria was not that harsh. For instance, if we want to compare educational groups, there needs to be a measure of education. Some of them did not have that. And some of them have quite abused study design. They didn't have a proper control group, etc. So actually there were only 9 left. And here we were quite desperate. How could we make something sensible out of this? Not a meta study, of course. So we looked upon each of these and tried to figure out if we could make any general conclusions. So there were some areas that turned up. Smoking cessation, of course, that was expected. Here we found 3 studies, and to give you some flavor what it was about, I will very quickly relate some of these studies. This was by Stanchik and from the Netherlands. It was a randomized control trial, and it was a web-based smoking cessation program directed towards the general population. And they noted a great participation in the intervention group by the low educated. That was promising, but they actually did not evaluate smoking cessation, so it was not very informative. The next one was a study from the United States by Cantrell and co-workers. That was a community-based smoking cessation intervention, also using a web-based RCT, which had 2 arms, and it included individuals with high educational level and low educational level. And actually, this pulled in the wrong direction. It was the individuals with high educational level that had a greater tendency to quit smoking, which is a similar experiment that they found in many other studies. The next one was from the Netherlands again, Wendel Vos. That was a community intervention from Limburg, the province of Limburg, and it was on smoking, diet, and leisure time physical activity. If we look on, it had 1 intervention and 1 controlled region. So here we looked at the smoking part. It will appear in 3 places since it had 3 components. But they couldn't find any change between educational groups regarding smoking cessation. So dietary habits, again, the Limburg study, they had a greater effect on individuals in the low educational group. So they adapted their dietary habits in a better way, but the effects were very small when you looked upon them, so we don't think it had a great potential of reducing health inequalities. There was a study from Norway, Överby and co-workers. It was a school fruit program, and they could reduce unhealthy snack consumption more among pupils from home with a high educational level. Yes, so it pulled in the wrong direction. So Cameron in Australia with co-workers, they had an infant feeding educational program, and the idea was to introduce very early good dietary habits to prevent overweight and obesity. So they had generally a better effect among high educated mothers, but it depended on the outcome. So it also pulled in the wrong direction. Physical activity, again, the Limburg study. It was a community intervention, as I mentioned. It had a greater effect on individuals with low educational group. Here it worked the correct way. It was a low education, but the effects were very small. In fact, they were quite similar, but there was a slight difference between these groups. It was not statistically significant. There was another study from Canada, Van der Ploeg. It was a school intervention on physical activity. And here it was the highest increase of physical activity among students with parental high educational level, again pulling in the wrong direction. So there were two that looked upon 2 studies of the 9 targeting mental health. Van der Waarden from the Netherlands, that was also randomized controlled trial. So the intervention had 2 arms. It was exercise and a psychoeducational program. And the purpose was to halt development of depressive symptoms. So first they screen for depressive symptoms and then they intervene in a high-risk group. But it was a general population. They had a slightly higher effect among the low-educated women. But we didn't find any test of significance, and probably it was not significant because the sample size in the arm were about 50 individuals. It barely reached the level of 100, which was the inclusion criteria. So we did not think that this is a powerful way of reducing health inequalities. De Socio in the US intervened by home visits for adolescent mothers. And they noted that women with academic difficulties in school, they had the greatest self-agency score gains. But we are quite uncertain what that would mean in mental health. It was sort of an intermediate factor. We found one study targeting participation in breast cancer screening, Kreuter from United States. And here, this was the only one which had a clear-cut result in the desired direction. The intervention was to increase participation in the breast screening program, and they had a greater effect, a much higher participation, considerably higher among women with low educational level. So here it was effective. So it was a meager catch in our trawl. We had to throw most of the fish aboard. They were too small or not adequate. So what conclusions could we make from this? Well, one obvious conclusion is that there were very few studies of high quality regarding community-based intervention. So maybe it was not surprising that the study that was presented before here, that they did not was not based on evidence, because there seemed to be very scanty evidence concerning these interventions. Yes, and what else? Well, we dare to comment some tendencies in what we saw. We noted that studies which did not utilize the community setting did not seem to have a potential effect on health inequality. However, studies that did utilize the community setting and involve them in the intervention, mostly in the school setting, we could see some study, they seem to be more promising. So interventions addressing behaviors which could be expected to be culturally embedded, that is smoking, maybe dietary habits, exercise, they seem to be more difficult to address with interventions that potentially could improve health inequality, while interventions addressing less embedded behaviors, participation in screening programs, seem to be more promising. Yes, so actually I have some other comments, but I think I will save that for the discussion. So this was, I make this short and I will come back with the other comments later. So the general conclusion, even if individual behaviors are addressed, there seems to be a need to involve structural and contextual factors in the intervention process in order to decrease health inequalities. I think this links to the discussion about how our inequality produced, and also the role of the welfare sector and health in all policies. But I think we can come back to that. So thank you very much.